This is Dr. Sargsyan in today's Exam 2 review lecture. And first, I would like to talk about dementia and delirium and what do they mean or what's their significance in primary care. Dementia you mostly will see in long-term setting or in home setting versus delirium you will see in acute setting. But you need to clearly differentiate what is acute, what's long-term, and you need to clearly differentiate what's the dementia and delirium. So delirium is usually short-term and it can be reversible. Dementia is progressive and irreversible. So another major difference is that dementia develops slowly and delirium develops clearly. Consistent finding in delirium, whatever the cause is decrease in cerebral perfusion. So it's really vascular problem, while in Alzheimer type of dementia, you see amyloid plaques. So what you are going to do when you are dealing with delirium, and most of the time, again, you will see the delirium in acute care setting. Post-surgical, again, is one of the most common one, and another option will be something related to medications, but even in post-surgical, it's really like long-term or short-term effects of anesthesia. So what's the treatments for Alzheimer's disease? How you would approach Alzheimer's disease? And the treatments, again, are very limited pharmacologically. So you will have the cholinesterase inhibitors and the NMDAs, or Namenda is the representative. They are adjunct or second line. So cholinesterase inhibitors are the first line, and like Aricept will be your first line, but NMDA will be second line. Also, this is been said many times, many places, that the treatment is just temporary. It will not improve, but it may temporarily slow down the progression of the disease. Again, diagnostic of Alzheimer's disease is very clear-cut. Basically, you will go by clinical presentation, but technically you cannot diagnose the patient until the post-mortem examination. So a small pop quiz, kinda. You need to be able to define those terms, what they mean, or this definitions, and find the matching terms. It will be better said that way. So for instance, agnosia is inability to recognize the objects. There are many clinical tools that will help you to diagnose dementia. Again, there is really no lab test, or there's the imaging use will be limited. So you can use these three tools to evaluate and diagnose dementia. Montreal Cognitive Assessment, or MoCA, St. Louis University Mental Status Exam, and Falstein's Mini Mental Status Exam. So what are these, and how useful they can be? So Falstein is together with MoCA and MiniCog are useful tools, and they can be used for evaluating the cognition in general. Mini mental status evaluation, it's probably most commonly used. MiniCog, which I didn't put it on the slide here, is also one of the other commonly used ones, because MiniCog is the clock drawing test, and they also ask the patient to have 3-item recall. and it really works well and it's easy to use. MoCA probably is the most accurate one because it can determine like very, very mild or minimal cognitive assessment. Oh, I'm sorry, cognitive impairment. So there are several psychiatric disorders, conditions, or I would say here symptoms may be present in dementia. Patient will represent with many disorders such as depression, anxiety, and out of the psychiatric disorders or conditions, anxiety has the most highest, not the most highest frequency because patients commonly exhibit anxiety due to lack of recognition of surroundings or being disoriented or scared. So this all leads to anxiety. Also, it's followed by depression, but anxiety is the most common one. And patients may also present with agitation and combativeness even, but truly it's not that common in patients with Alzheimer as compared to anxiety. So there are many quality of life issues coming from here when we're talking about patients who have dementia and Alzheimer type dementia. What's important, how to provide the adequate quality of life. And most often family will put their interest ahead of patient's interest. So they want the patient be around longer. But does it really affect the patient positively? So placement of feeding tubes is one of the examples that how decision making of the family may affect the quality of life of the patient. But for instance, feeding tubes, they are not really enhancing the quality of life, and those who argue that they would say it will increase or improve the nutritional patient with Alzheimer's disease, it really would not. So at the end, the nutritional results are the same, but the quality of life is impaired. So again, the interest of the patient should be considered when treating or developing the treatment plan for patients with Alzheimer's type dementia. So sensory impairments are common, and the most common factor that affect development of sensory impairment is the age. So the older we get, the more visual and auditory impairment we developed. And the first example is very easy. If you are approaching through or approaching to 40-year-old mark, then you may need reading glasses if you even didn't have any problems with vision before. So what are the challenges these patients may face with sensory impairment? And the challenges are very clear-cut because it will again affect quality of life. It will affect the functional ability, and at the end, if not treated, may affect the mortality. So morbidity from these disorders may reflect as mortality, and there are many ways to illustrate this, and they say like if the vision or hearing not corrected, they may bring the example of elderly drivers, but also the visual may affect the ability to move around and see the obstacles, and some in one person's dwelling and so on. So, but again, this will result at the end in increased mortality. So let's talk about hearing loss versus, and let's talk about hearing loss, not versus. There are two major types of hearing loss: sensory neural versus conductive. And sensory neural is obviously related to malfunction in cochlea or central auditory pathways, while we are talking about conductive loss appearing from conductive losses appearing from the dysfunction in the external auditory canal or middle ear. So basically the conduction. So basically you can say external versus internal. It's important to know this definition. So these two, sensory neural and conductive, can combine and have a mixed loss that has both sensory neural and conductive shares or components. Okay, so another part of our little quiz continues. So please look at the last line in this slide and define physiologic anischoria. Okay, let's talk about visual impairment or sensory impairments that affect vision. So cataracts are very common, and in primary care we may not really be able to treat them, but we certainly may diagnose them and refer them. So, and it's very, very treatable. What happens, crystalline lens is getting more opaque, and the image we see gets blurrier and blurrier. So retina has no problems, but because the image focused on the retina is blurry, then this results in vision loss. Cataracts are a direct consequence of aging. So the theory is that everyone will develop cataracts if they live long enough. So there's really no genetic component, there's really no nothing that like viral or biological component that will affect it, external factors, but it's consequence of aging. That said, the external factors and environment still can affect it. Certain diseases such as diabetes and corticosteroid use, for instance, or extensive ultraviolet light exposure can facilitate the development of cataract. So when patient you see comes to the clinic and with age-related cataract, is the complaint is a progressive loss of visual activity. There is actually no pain, no headaches. Headaches may be present occasionally, but it's not common, and but it's progressive loss. So on examination, you may notice asymmetric red reflex. That would be one of the most indicative signs for cataract. Again, there are no drugs, no medications to reverse the opacity of the lens. However, the surgery is available and successful and safe, and it's outpatient procedure this day. And the only word of caution with the surgery that surgery should be exercised like last resort. If visual activity is sufficient, it's not recommended to proceed with surgery. When visual activity is impairing function, then it's recommended to proceed with surgery for cataract. So dacryocystitis is an infection of the lacrimal sac, and when tear duct get obstructed, then infection is more prone to appear. So patients may present with complete obstruction or partial, and regardless if patient has that, then they will be having chronic tearing. Okay, but when patient presents with actual dacryocystitis, patient will have I don't want to call it mass, but you will see like swelling and right next to the inner aspect of the eye, and you may try to apply lacrimal sac pressure, and you may see like there is a mucus coming out into the eye, into the punctum. So this may indicate that there is the actual obstruction, obviously, and something needs to be done. The most definite way to deal with it is surgical, but you also may do more gentle approach, and usually warm compress or like conservative management with warm compresses may help, and topical antibiotics also may be helpful. Okay, so if the rule is really you can start even broad spectrum oral antibiotics, so basically, and that may work, but if the lacrimal sac becomes painful, then or having already like developing head, so then IND of the abscess is beneficial. So really most of the time, or I cannot say most of the time, but quite often you will see that this will be painful and patient will need some IND done. So there are many eye disorders, but we will not be talking about all of them. And the last one is the dry eyes. So dry eyes can be divided into two categories. So it's aqueous deficiency versus evaporative dry eye syndrome. And the evaporative dry eye syndrome is basically that eyes are drying out. So what to do in this situation? Just artificial tear is the best approach to deal with like genuine dry eye syndrome, but basically when eyes are drying out. And also, or anything that touches the eyes at this situation needs to be very gentle. So it's very important to use non-tearing shampoos, like basically baby shampoos, the greatest invention of the humanity, like the soap that doesn't induce tears. And usually dry eyes are controllable, and anything drastic like steroid eye drops should not be used consistently, or if it's used, then it should be used for a short period of time. Aqueous deficiency is the disorder when the fluid isn't produced or tears aren't produced adequately. So it's not really drying syndrome, but it's inadequate production syndrome. But the result is the same, dry eye. So the way to determine it is to conduct a Schirmer test, and a Schirmer test is basically will confirm that patient has aqueous deficiency. Next topic is skin disorder, and then let's talk about bullous pemphigoid, or BP. Is really a very interesting disease. It's not an infection like many would misdiagnose, but it's actually autoimmune disorder, and it's autoimmune disorder that results in blisters. So when you see BP, that is the you will notice that a patient has numerous blisters on the skin, and this blister are a result of IgG activity, and which eventually will bring these blisters. And IgG's antibodies are directed to BP antigens. So basically, not everyone will develop it because not everyone has this reaction to this antigen. So this would result in complement cascade activation, and of course, this will bring all the lymphocyte and eosinophils and to the skin basement membrane, and also patient will have influx of enzymes that will be degrading the membrane, and it all will result in a blister. So there are two stages. There is a prodrome stage, which is erythema and eczema, and this presents as papules, and then bullous phase will appear. And bullous phase has intense pruritus, and which is accompanying the blister formation. So what's interesting that this is not an external or an infection. The blister formation is very symmetric on the body. So they will be distributed on the abdomen and anywhere on flexor aspect of the extremities. How to diagnose this? Again, the gold standard is direct immunofluorescence. And what direct immunofluorescence will show, again, the same IgGs I was talking in the beginning. So those IgGs will be collected or kind of focused, located on dermal epidermal border. And again, contrary to popular or non-popular belief and misdiagnosis, even this looks like infected or even a burn. It's not an infection or a burn. So how to treat this? You just basically want comfort for the patient. You want the itching to go away, and you want to get rid of the blisters, and obviously itching plus blister will result the destruction of the skin integrity and will result in secondary infection. So you may even proceed with topical steroids and then go from there. So topical steroids are effective in treating localized disease, and you can apply topical steroid ointments or creams until it's healed. Systemic steroids can be initiated and they can be given to the patient until the skin is clear if we have more widespread involvement. Sometimes patient would need something like stronger and again more targeted to immune system. So even using methotrexate has been shown to be effective. Let's talk about hidradenitis suppurativa or HD. This is an interesting disorder. There are many people who suffer from this, and again, the origin of this is hormonal, although it's affecting patients on the surface of the skin. So the origin of HD and is related to excess of adrenal androgens and affects female and male population pretty much equally. So this is a disorder of apocrine glands, and you know you have apocrine glands and epicrine glands, and apocrine glands are those that located in the groin and in axilla. And these are the glands that are responsible for the odor and smell of the sweat, while epicrine glands are located all over the body, but they don't really contribute to development of the smell. So apocrine and epicrine. So apocrines are affected by this disorder, and that's why the patient will exhibit the signs in those locations in axilla and in the groin. The exact cause, even I said androgens, is not known, but again, there is a research that's going on, and hopefully one day we'll find out. So the course of disease is progressive and can have relapses and remissions, but unfortunately this may result in permanent scarring. So when this happens, the bacterial invasion of apocrine glands develops into severe infection of these glands and may result, even if the infection resolves, may result in scarring. So the treatment has variety of approaches, and the steroid injections are possible, antibiotics, surgery, laser surgery, even something like isotretinoin, which is really for acne. But again, the mainstay is the antibiotic treatment, and erythromycin has been shown effective. Also, tetracyclines has been shown effective. But again, the course of disease is waxing and waning, and unfortunately severe scarring, and this is really one of the disorders they truly requires individualized approach, and there may be several ways to address this. So consultation with dermatologist may be appropriate. Hyperhidrosis can be described like excessive sweating, and usually patients will exhibit excessive sweating on the palms and soles, and also you can see complaints of axillary sweating, and also sweating can be related to ingestion of food and many other presentation. This is a complex disorder or complex description because there may be many sources that contribute to this. So in general, when someone presents with excessive sweating, it's something related to ovarian function or beginning of the menopause. But there may be many other options, many other sources like thyroid disease dysfunctions, thyroid gland dysfunction, Parkinson, and even medications can cause this. So how to diagnose this? It's obviously patient history and presentation. The treatment is one of the most common one is 20% solution of aluminum chloride hexahydrate, and it's a Drysol, the commercial name, and it will affect the sweating intensity, especially in hands and soles and axilla. So what this treatment does, it's very interesting because it's so-called denervation. I know you heard about denervation of heart when there's a heart transplant, but this is denervation of eccrine or epicrine sweat glands. So again, eccrine sweat glands or epicrine sweat glands are those that do not really produce smell, but they produce fluid. Okay, so there are many other options. Surgery, like cutting basically D2 and D3 nerves, can 100% cure the palmar hyperhidrosis, also liposuction of auxiliary sweat glands, and so on. So, but again, the aluminum chloride hexahydrate solution is the most common, cheap, and effective option. So, and it works. Vitiligo is a disorder that is related to dysfunction of melanocyte in the skin and also in the hair follicles. Basically, this everything in skin color related and in hair color related to melanocytes. When melanocytes don't work, then we are losing the skin color. And when it's vitiligo, the effects can be very long-term or basically lifelong, or it can be like very quick, this rapid disappearance of the pigment. Okay, nobody knows what causes that, but if the disease developed, then it leads to progressive loss of pigmentation or hypopigmentation, and it happens usually on sun-exposed areas and exterior surfaces of the body. Okay. Sometime the best approach will be referral to dermatologists, and you know, well, physical examination really you would see visually that vitiligo is present. So how to treat it? Treatment may include mild potency steroid cream, also the cosmetic creams like the makeup can cover it up, but and also tanning creams may help to darken the affected area. Another important intervention to consider here, the patients with vitiligo need to use sunscreen with a relatively high SPA factor because the unpigmented skin is very prone to burning. Basically, there is no melanocyte or melanin protection. So another approach was depigmentation. If there is a extensive involvement of body surface, then depigmentation or elimination of pigmented areas in the skin is possible. So again, this all is dermatology domain, but you may be the first one in primary care to diagnose. Seborrheic dermatitis is another interesting disorder. And seborrheic dermatitis is a fancy name, but you may see or hear people calling it dandruff. And if seborrheic dermatitis appears on the scalp, if it appears on the face, and then seborrheic dermatitis will present with greasy, erythematous, like marginated plaques, not papules, but plaques because they are large. So what can be done when patient presents with this? And anti-seborrheic shampoos, like for hair, and it's usually they have either ketoconazole or selenium sulfate in that. It can be helpful to eliminate the dandruff. And also another option will be ketoconazole cream, especially if it's on the face, it's not a shampoo. Obviously, you cannot use the shampoo on that. So some patients may be preferring to take something systemically versus ointment. So for those, an option will be using Sporanox, iatroconazole, which is Sporanox has both anti-inflammatory and anti-mycotic or antifungal properties, and most commonly you hear when we give Sporanox to onychomycosis, to nail fungus. But again, in these situations, Sporanox may help. And now we're moving to ENT section of this presentation. First one I want to talk is parotitis. And it's parotid gland inflammation. Doesn't matter what caused it, you call it parotitis. Can be bilateral. Bilateral is usually viral, like mumps, and unilateral bacterial. So it can be, again, bacterial, viral, fungal, or mycobacterial origin. So viral is very common, and again, like mumps infection, and will present with bilateral. Bacterial infection will usually show on one side, and elderly are much more prone to it than younger people. And again, it will be unilateral enlargement and even cellulitis. Not only microorganisms will be causing parotitis, but there are many other things that can cause it, like even oral hygiene that is poor, that can result. Obviously, that's also bacterial overgrowth, but it's not an infection really. It's just overgrowth of own bacteria, salivary duct obstructions, and the radiation from, let's say, cancer treatment, dehydration and hypovolemia, and so on. So it's not only bacteria, viruses, or fungi that can cause it. So treatment can be very tricky, and clear cut. If it's viral, basically it has to run its course. And non-surgical treatments can be for bacterial parotitis, can include antibiotic treatments, and sometimes it's so severe that it will require admission to the hospital and parenteral antibiotics. What's important with this, if you suspect bacterial parotitis, and I think this should be all done in the hospital setting, you will end up doing culture and sensitivity of parotid gland, because multi-drug resistant organisms can be involved. So that's why it's important to do culture and sensitivity. So sometimes steroids are used, but steroids really, like we know, they don't really cure or fix or help the diseases. Well, they help the diseases, but they help the symptoms. So, and again, there's really multifactorial character of this disorder, and that's why it's important to determine the origin and then treat accordingly. Epistaxis is a very common disorder, and nosebleed is probably one of the most common disorder, but there are many predisposing factors. It can be something very benign, like the humidity in the house in the winter. The house is dry, so it nosebleeds, versus trauma versus the bleeding disorder, clotting disorder. So it needs to be investigated. Sometimes some benign and malignant tumors, of course, will bleed. Vascularity of the tumor is important, such as, and a good example is inverted papilloma in the nasal mucosa, which is highly vascular and can bleed. So physical examination in epistaxis may actually involve examination and treatment concurrently, because in this situation, you may ask the patient already to help you to stop the bleeding, contrary to popular belief. And if you didn't catch or grasp anything else in this lecture, please remember this. The patient needs to tilt head forward, not backward. Again, it's tilting the head forward and applying the pressure to the affected nostril. So sometimes you will end up giving some vasoconstrictive agents like epinephrine or even cocaine as a vasoconstrictor, and sometimes it can be packed with cotton, and also in some cases patient may need to be hospitalized or seen in emergency room, and cauterization can be performed. But again, it all needs to be determined what's causing it. Is it, again, malignancy? Is it just the air isn't humid enough, or it's trauma, and the patient needs to be treated accordingly? Okay. Allergic rhinitis, or some would say chronic rhinitis. It's an important and very common disorder because it's a condition characterized by runny nose and, of course, sneezing and itching, and it's all the name, it's in the name, allergic. So patient may get so bad and even develop fatigue and headache, and even cases with cognitive impairment were described. So again, if there is no allergen, there is no allergy, there is no allergic reaction. So there is no allergic reaction. Treatment is very simple and easy. But before doing that, you need to establish what exactly causes this, and you may not even find out. But so physical examination is really focused on one thing, on the nose, and you would use a nasal speculum or whatever otoscope and look in the nose. What you would discover, and this is very important in assessment, and I know you know this, but I'll say it again, the nasal mucosa is very pale, while when you have something bacterial or viral, the mucosa is very injected and red and pink. So anyway, but if it's allergic reaction, it's pale. Okay. And the pale color comes from work of histamine and leukotrienes, and basically those are the drugs, antihistamine and anti-leukotrienes, you can use to treat too. Okay, so how to treat? Again, the easiest and most effective, or maybe not easiest, but most effective one is the getting rid of the allergen. And if you do that, you will be a wonderful provider, and you will just fix this problem. But sometimes it's not very easy, and sometimes it's not possible to determine. So if it's not possible to determine, or it's not easy, like it's in the environment, like pollen, then maybe you need to proceed with some kind of treatment. The steroid inhalation or intranasal node inhalation can be very effective, and it's the first line still. So, and you can use something like Flonase. Okay. So intranasal steroids work, also antihistamines, especially second generation antihistamines, they work, and also many other approaches are possible. Non-pharmaceutical treatments may be even more preferable. One of them is nasal lavage, basically washing the allergen out from nasal mucosa, and this is like an excellent option, let's say for someone who is pregnant or breastfeeding, and you really don't know, like most of the medication we have are category, if they're deemed safe, they're not really that safe. There were no human studies, so they may say category B. So again, the safest and most really appropriate medication in allergic rhinitis will be something like nasal lavage or saline irrigation, or and eliminating the allergen. Another important disorder is vestibular neuritis or labyrinthitis. Labyrinthitis is common, and it shouldn't be confused with the Meniere's disease because the presentations are slightly different. So when you have labyrinthitis, a patient complains of severe vertigo, patient will have nausea, vomiting, and they cannot keep balance. They will have disequilibrium, and this situation will last for few days. So the nausea and vomiting will go away, and the vertigo and disequilibrium will stay for up to few months. So labyrinthitis is the inflammation of the vestibular nerve, and also otitis media can cause it. And also there is more and more the association with herpes type 1 or herpes simplex type 1. So again, if patient has vestibular neuritis, they will complain of vertigo, nausea, vomiting, and head movement will be aggravating those things. Okay. Also, tinnitus may be present, but what's important in labyrinthitis, the hearing is not affected. On physical examination, hearing is normal, but you may notice that patient will have the spontaneous nystagmus, so rotary nystagmus or horizontal nystagmus. So, and it will be away from the affected ear. So if you suspect Meniere's disease, and you may even consider MRI for your future evaluation because you want to rule out the possibility for tumor. So Meniere's disease, unlike labyrinthitis, it's coming with hearing loss. Labyrinthitis does not have hearing loss. So if you suspect Meniere's disease, so basically everything is kind of the same like labyrinthitis, but hearing loss, then you may do MRI. And MRI, you don't want central nervous system lesions, you want to look what's going on in the brain. So again, Meniere's disease versus labyrinthitis is two different things. And, one may be very serious. Both of them are serious, but the consequences may be very different. So when, again, back to labyrinthitis, when you are treating labyrinthitis, you want to get rid of vertigo, nausea, vomiting. And if it was related to infection, get rid of the infection. So you treat it accordingly. If you determine patient has infection, then you would treat them. And otherwise, you will work with them over long term, and sometimes you can have the balance exercises or labyrinthitis exercises to improve their condition and tolerance. And just when patient present with acute start of labyrinthitis, it may be appropriate to start steroid therapy at that time. So cholesteatoma is an abnormal collection of epithelial cells in the middle ear. So if you look in the patient's ear who has cholesteatoma, you may see behind the tympanic membrane some white discoloration or collection, something like sits there and it's not fluid. There is no scarring usually, and usually the history may be even without any middle ear involved or no otitis media history. Okay, so what's the reason patient will come to you? Patient may come complaining of otorrhea, basically something, fluid is coming out of the ear, or hearing loss. And that's the reason they'll come to you. But it won't be presenting like middle ear infection, like tympanic membrane will be intact and looking good, but you may notice something on the back. So what's the objective is how to treat it is to remove the dermis from ear canal and also prevent the bacteria getting back into ear canal. Okay. So also basically you want to treat the infection if there's infection. Surgery will be the ultimate treatment to remove whatever collection of epithelial cells are there, and that will resolve the issue. But again, if symptoms are not severe, you may pursue with conservative treatment. Cerumen impaction is one of the most common problems, and lots of people have it. It can happen to anyone, and the easy way to prevent it is clean the outer ear canal, and that will help with recurrent cerumen impactions. It's also important to deal with it very seriously, not light approach, because sometimes you see that the practitioner will say, it's just impaction, let me just pull it out, but the consequences can be grave. First and foremost, it's important to do a thorough ear examination and see that the tympanic membrane is intact. Okay. And you can use curette to pull it out, or you can use carbamide peroxide or cerumenolytic to get it out from the ear. So there are many options, but again, the patient will experience big relief. Sometimes they may experience even hearing loss in affected ear, and this will help tremendously with their situation. But again, thorough examination determined that tympanic membrane is intact. Then prevention will consist of keeping the external ear canal or outer ear canal clean, and also you can use cerumenolytic, and there are many others on the market, but carbamide peroxide is one of the most common ones and FDA approved. So exam format is the same. It will be open book. You will have 60 minutes. You will not have option to go back when you took the question. Please do not change the answers. First answer you pick is the correct one. The questions will be randomized. So question number 1, if it's on your test, your friend's test may be question number 15, and so on, and question sequence is randomized. So A, B, C, D, maybe B, C, D, A, so on someone else's, so the answer. So please take the test, your internet connection quiz, to make sure that your connection isn't slow or nothing wrong with it, there's no lag. If you are experiencing problems, please call the support with technical support, and they will help you determine, is it your computer, is it something with the internet, or is it on the ETSU side. But anyway, either way, it's good to take this test. And this is really it. I hope you guys have a good preparation for the test, and if you still have any questions, you can contact me or your respective section instructor.